I'm Dr. Michael B. Sisti, talking to you from my office at the Neurological Institute of New York at Columbia University Irving Medical Center, New York Presbyterian Hospital. I'm going to talk to you today about a subject dear to my heart. It's radiosurgery. This is the use of precision small doses of radiation on an outpatient basis to treat certain kinds of lesions within the brain. You may wonder why a neurosurgeon who specializes in the treatment of rare, difficult, and exotic tumors of the brain with microsurgery has a foot in the world of non-surgery. Well, a little bit about that has to do with the history of neurosurgery and some innovators in the 20th century, as well as my own personal background. So maybe to put radiosurgery in context, it's a good idea to review the history a little bit so you can see how instrumental European neurosurgeons principally were in the 20th century to bring this incredible technology to people with lesions that are in the brain that are too dangerous or should not be operated on. So these ideas started to occur in Europe after World War II mostly, and the type of technology we use here, we really can trace it back to a single neurosurgeon at a single institution in Stockholm, Sweden, Lars Leksell, who was a superb neurosurgeon in his own right and director of the Department of Neurosurgery at the Karolinska Institute in Stockholm. And one of his innovations, and there were many, was to design a system using gamma radiation from radioactive cobalt to target very small, very precise lesions in the brain without making an incision on a patient, so there'd be no blood loss. And this was principally to do lesions that were in the deep central core of the brain that were extremely difficult at that time to treat by surgery. The shocking thing is that Dr. Leksell and his colleagues began to do this in the late 1960s, before CT scan, before MRI scan. And when they finally developed a prototype system, the commercialization of this technology, meaning the first machine sold, was sold in 1984. That's a pre-MRI machine. So although this sounds like space age, exotic, just invented kind of technology, in point of fact, the history of radiosurgery goes back almost 50 years. And of course, just like all technologies, think of your cell phone or your computer, or anything that you have in your possession, there's been an exponential growth in the indications, the accuracy, the speed, the reliability of not only the Gamma Knife platform, there are many other kinds of excellent radiosurgery platforms that, and they go by great names too, like CyberKnife, which uses a linear accelerator, the ZAP. There are other kinds of exotic radiation forms like proton beams, and they're all really good. And they all really do a good job. But just like any kind of technology, each device that you use has certain pluses and minuses, and depending upon the doctor you are, the institution you work in, the kind of stuff you do, you may choose one kind of device over the other. But honestly, if you know what you're doing, the machine that you're using is probably not as important as your judgment about what it is you're doing and how much you should have and how that fits in with your entire management of your neurological condition than specifically whether you're using a Gamma Knife or a CyberKnife or a linear accelerator or any other kind of excellent world-class kind of radiosurgery equipment. So my own personal story is kind of unusual. I was always interested in medicine, but my undergraduate degree is in chemical engineering. I have a BE, Bachelor of Engineering, it's an unusual degree, chemical engineering from Cooper Union here in New York. That was a real struggle, I'll tell you. Between neurosurgery and chemical engineering at Cooper Union, no, neurosurgery is easier, it's true. But in any event, I was studying that in the 70s, and of course that was when the world of digitization, integrated circuits, computers, computer language was really beginning to hit its own. Of course, in engineering, really came way ahead of medicine, but in any event, I had a real deep familiarity from my engineering background about computers and programming, and how digital interfaces were going to change the world. And when I came to medical school here at Columbia in 1977, I think I got in here because I had such an unusual background. I don't think they'd ever seen anybody quite like me. I think they were wondering why I wanted to be a doctor, but I kind of knew that medicine at that point hadn't gotten to the point where engineering and computer science had gotten. And we were just getting from Europe, from England, the first CT scanners, the first ability to look inside a living person's brain and see what they have in a minimally invasive fashion. And that's a digitally based technology that's run by a computer. And when I finished medical school and started my residency, I had the great fortune of working at the NIH at the very start of the AIDS crisis, in which, at least in the United States, some very old technology of reaching small, difficult, impossible to operate lesions of the brain, they're called stereotactic systems, they've been around for a long time, were being joined to CT scans. And so a series of computer programs and sophisticated technical equipment allowed us for the first time to get a CT scan and in an awake patient, through a 3/8-inch hole, place a probe in the brain and do a biopsy on somebody who had no clue what they had and couldn't operate on to figure it out otherwise. And so these biopsies have been done before, but they had done from angiograms or plain x-rays. They hadn't been done from CT scans and computers. And of course, the revolution, just like everything you know, took off at exponential speed. So now all of this is completely routine. But at one point in the 70s and 80s, to find computer-guided brain surgery was uncommon and unusual. Here at Columbia, we mostly used it during the AIDS crisis in the 1980s to figure out what was going on in the brains of our AIDS patients, which was very complex and confusing. But also, people were thinking ahead, like Dr. Lexell and many of his other colleagues in Italy and Germany and other places in Europe and in the United States, that, hey, if you could put a probe in somebody's brain and do a biopsy in a place you couldn't operate, why couldn't you concentrate a beam of radiation there and destroy, with a precision dose of radiation, a very small tumor that's inoperable in the brain? And that's really what radiosurgery is. Radiosurgery has some limitations, at least the Gamma Knife. It's essentially a brain-only system. It works better on a smaller lesion with less symptoms. And from 1984, at least here in the United States, to 1916, and here at Columbia to 2016 to 2017, we did all our radiosurgery in a single treatment session. So it turns out our radiosurgery program, which I spearheaded here at Columbia, because after all, based upon my engineering background, the work I had done at the NIH, and the support from tons of mentors and other kinds of people, I was really hired here to start the radiosurgery program and bring not just myself, but everybody up to speed on this essential kind of technology. Of course, I wasn't the only person doing this. This whole thing was rippling around the globe, but I just happened to be the right person at the right place at the right time, and I was tasked with this job. And we started out with our own homemade system here at Columbia in 1989. We did the first radiosurgery procedure, as far as I know, in the state of New York. So in 1998, we decided to leave our homegrown system behind, at which we had treated over 700 patients, and change over to the Gamma Knife system, which we selected because of the track record of the technology, the publications from many centers in Europe, and particularly the University of Pittsburgh here in the United States, really put the Gamma Knife on a very solid background of reliable, reproducible results based on the technology, no matter where you worked. And in some ways, I say it's like, if I prescribe an antibiotic for you, well, I didn't really make the antibiotic. It was made in a pharmaceutical factory. And whether you take a 500 milligram tablet of penicillin in New York or San Francisco, it's the same drug made at the same manufacturer. It's basically going to have the same effect. And so Gamma Knife's a little bit like that. It's very different than surgery, which is really dependent upon what your surgeon is doing in that one specific instance. The Gamma Knife is highly repeatable and reproducible results at all the Gamma Knife centers around the world, as long as you use the technology the way it was meant to be used. So we've been extremely happy with this technology, and of course it's evolved like all technology has evolved. It started out, the first kind of systems we use, I'll just show you. I know this looks pretty draconian, but this is an old-fashioned stereotactic head frame, and these posts and these titanium pins would be screwed into your skull, 2 places in the front, 2 places in the back. This would be locked into a certain kind of machine, and when your head is in this and we do a scan on you, then everything inside this space, the computer, either from CT scan or nose or MRI scan, can find anything to literally 1/10 of an inch inside of your brain. And so we've published a lot on this here at Columbia, and I would say up to from 1998 to 2016, all of our patients were done in devices like this, with pins put in your forehead and the back of your head, and everything was done in a single treatment. Our Gamma Knife is in our children's hospital. It's unusual, but we have the capability of doing pediatric general anesthesia. I don't do children, but some of my colleagues do, and so everybody wants to know why they're going to Baby's Hospital here at Columbia to get their Gamma knife. Is because sometimes we have to treat, children with this, and they need general anesthesia for this. But adults, it's done with local anesthesia. But what's really been for me a huge improvement has been the most recent type of advancement, the Gamma knife, which they all have names. The last machine was called the Perfection, that type of Gamma knife. The new one is called Icon. And Icon, instead of working on these invasive masks, frames, which still have a use, we still use them from time to time, they work on these moldable plastic masks. We call it the Gamma Facial because this piece of plastic comes out of an oven, it's warm, we mold it to your face, we call it the Gamma Facial. This thing holds you extremely still. The machine observes this thing with you in it. It's very accurate. Our physicists have published on the accuracy of this. We've done almost 500 patients already. We've actually published the first 100 patients that we did here at Columbia. As far as I know, that was the first large series published. If you want to read it, it's in Neurosurgery in 2019. Just shows what you can do with the Icon system. And I'm using this about 95% of my patients. What I love about this is it's truly non-invasive. Our Gamma knife is on the Broadway side of our campus in Baby's Hospital. There's a subway stop there. I let people get on the subway after these treatments and go back to work. But in addition to not having to put the pins in your head and being extremely accurate and precise, and I'm very happy with all of that, it also allows us to take this mask on and off. So instead of giving you the radiation in one single treatment, radiosurgery can be done in 5 separate treatments. And there's huge advantages to that. It means we can treat larger lesions more safely, we can give more radiation, and we're extremely hopeful that this has been a big advance in our ability to expand the scope of indications and safety for radiosurgery. What's true is we don't have the results to prove that yet, because many of the lesions we're treating that are benign, it takes a long time to publish results that are meaningful, and we're certainly doing that. We did that in our experience in the frame-based systems. To give an idea, radiosurgery for acoustic neuroma is a benign tumor of the nerve of hearing and balance that I have a lot of surgical expertise in, but also to go through our 700 or some odd patients with tumors in that area, from the time I did the first one here with the Gamma knife in 1998 to the time we collected the data in 2015, that series was just published last year in 2019. You can also read that in Neurosurgery if you want. I feel sorry for if you read that paper, but it's very technical, but in any event, it's there and you can read it if you want. But it just goes to show how long you have to, especially if you're dealing with benign tumors, which is a large part of my practice, how long you have to be dedicated to collecting the information to show that what you're doing is as good or better than what you did before. So I freely admit this is new technology. I've been extremely happy with it since I've been using it. I'm in the process of collecting that information, as are other doctors who have this technology, to make sure it's at least as good as what we did before, and hopefully it'll be better. Certainly it's more versatile, and patients obviously like it a lot better. That may not be an indication to do it, but certainly I have very high hopes for this, and my preliminary experience of using this over the last 3 years, I have not been disappointed with it. But I admit it's going to take me a lot more time to replicate the excellent results we had when we're using these frames, and to expand the indications of this device to show that it's really useful. And that's the job of people like myself and my colleagues in radiation oncology and radiation physics at places like this at Columbia, and of course other places as good around the country and the world. Is everybody who has this kind of technology is probably thinking about the same thing I'm thinking about, is how can we do better with less for our patients as technology gives us more options to treat patients. So when do we use this? And those of you who may have looked at other things on our website have seen that I really like using this a lot for small benign tumors such as acoustic neuromas or meningiomas in difficult to access locations, or sometimes I use this as an adjunct to surgery. You know, you've got this gigantic tumor and I take out 95% of it, but a little part of it looks like, hey, if I touch that part, maybe you never move your face again, or you won't swallow correctly, or could affect some other critical function. And because benign tumors are sensitive relatively to very small doses of radiation compared to many nerves and the brain itself, you can do things with this Gamma knife and this kind of technology that is not advisable, at least in my hands, to do in surgery, as I'm really trying to emphasize the quality of life over the extent of surgical resection. So in my benign tumor practice, this has been extremely useful in the treatment of tumors that involve the nerve of hearing and balance, both neuromas and meningiomas, and other kinds of neuromas and meningiomas that are in difficult to reach locations in the brain, that are small, that are minimally symptomatic, or that are residuals from surgery. And I think everybody wants to know what the competition is between people who operate and people who do radiosurgery. It's not a competition. These two technologies reinforce each other's effect. And here at Columbia, it may be different than some institutions around the country. Not just myself, but my colleagues, we've all do our own radiosurgery in our area of surgical expertise. So I don't do all kinds of tumor surgeries. So I only do radiosurgery on the things that I'm a surgical expert on. And so I think if you're thinking about radiosurgery, although the machines are commercial and they're highly accurate and the results are really reproducible, and I don't know whether you get Gamma Knife in New York or San Francisco, you're going to get the same excellent result. But should you get the Gamma Knife, and when should you get the Gamma Knife, and what if there's a rare problem from Gamma Knife, and do you know about the disease? Do you manage these patients on a daily basis? Do you manage them with observation? Do you manage them with surgery? Do you manage their medications and all the little unusual things that happen in the course of these kinds of problems that you can't read about easily in the book or the literature? You know, experience teaches you a lot over the years about these exotic tumors and what patients really need. And I think surgeons who do their own surgery and who master the radiosurgery technology, it's a win-win for the patients. And I look back to the inventor of this technology, Lexell, who was a consummate neurosurgeon, superb neurosurgeon, a great inventor. And he did his own surgery, he did his own radiosurgery. And so here at Columbia, myself and my colleagues, I think we have 12 certified users, maybe more. Each one of us who does surgery, myself included, has mastered this technology for the benefit of our patients. And I think it just factors out a little conflict of interest. I don't even really think it's a conflict of interest. I think it's just that when you have a tool and you know how to use it, and you have confidence in it, in your results, and you've published on it, then I think you just can get a better result for your patients than if you just did one or the other, at least in my opinion. I know that may not work for everyone, and that's fine, but I think that's why people want to come and see myself and my colleagues here at Columbia with these issues, because we have a foot in both worlds. Monday is my Gamma Knife day. Monday I don't go to the OR. I do my Gamma Knives on Monday morning. I operate on Tuesdays and Wednesdays. I like starting my week off. You have my kind of job. It's great to start your week off when the patients you're seeing that day, they're going to go home. When you're done with them, they're going to go back to work, if not that day, the next day. And those patients don't really look very scared in the end of the day. They come in. It's a nice way to start your week because they know they're not going to the OR, and they know that they've been pre-selected for this treatment. So it's very likely to work. Now, Gamma Knife, additionally, in treating benign tumors, of course, has a huge impact on treating patients with cancer. I wish it was more effective on patients with primary brain tumors than it is, and that's actually an unusual. Many of my patients with glioblastoma or other kinds of gliomas are always asking me about the Gamma Knife because they know that I do it. And many of those types of tumors, because of their biology, are not really amenable to radiosurgery. They're too infiltrative. This technology is too accurate and too precise. It's too much like surgery. They need a different kind of radiation that's actually more complicated and sophisticated, in my opinion, than Gamma Knife. But patients with metastatic cancer, so metastases means you have breast cancer, lung cancer, colon cancer, melanoma, or other exotic kinds of primary cancers that have traveled to your brain through your bloodstream. And so here Gamma Knife has huge advantages because if you have systemic cancer, you already have a lot of issues going on with your internal organs, with radiation or chemotherapy. The last thing you want to do is add neurosurgery to that. Now look, patients with metastatic cancer, sometimes they don't have a diagnosis, sometimes the tumor is really large, causing neurological problems, and you're going to need to have surgery first. Well, with the mask, you have a lot of options. You could, in a metastatic cancer, if you take it out, how do you know you got every last microscope? You have post-operative MRI scan, it shows that the tumor is gone, but no one would ever convince me that there wasn't a microscopic tumor cell left. So those microscopic tumor cells could regrow the tumor. So instead of radiating your whole brain, maybe it's not a bad idea, and we do this here all the time, to give you a boost to the cavity of the surgical resection with the Gamma Knife mask, either when you're in the hospital or when you've recovered from the surgery shortly thereafter, so the tumor doesn't grow back while we're trying to figure out how to treat the cancer in your body. You could even give this before surgery sometimes, and then occasionally the radiosurgery may make the surgery easier for you. So this can be done not at just one location. We can treat multiple brain lesions in a single session. I've done up to 20 in a single patient in one session. And the advantage of that is if you have small tumors and not a lot of symptoms, the radiation dose is so precise, you can stop the tumor from growing without affecting the entire brain. Because traditionally, and still done, sometimes occasionally when you have metastatic cancer of the brain, you have to radiate the whole brain. But if you think about it for a minute, if you're radiating the whole brain and you survive a period of time because your doctors, your oncologists have managed to control your cancer, then the effects of that radiation therapy to your whole brain, given the fact that you probably got chemotherapy and other kinds of medications, of course I say it prematurely ages your brain. And it doesn't do that for everyone, but it could for a lot of patients. And it sort of defeats the purpose in a way of the quality of life if you're a cancer patient, that we're going to do a treatment on you that could have serious effects on your personality, your behavior, your intellect, your memory, your energy level. And here we're trying to do as much localized radiosurgery for our patients with metastatic cancer and avoid whole brain radiation therapy for them. And this is, of course, being done in many centers around the world with excellent results. We have excellent radiation oncology here. I'm the co-director of radiation oncology here since the center opened. I've only worked with 2 radiation oncologists the whole time I've been here. I'm currently working with Dr. Tony Wang in the Department of Radiation Oncology. He's my co-director. We work together on Mondays. It's always great to have a radiation oncologist in your team because they look at you differently if you have metastatic cancer. And also, they have many other sophisticated ways of doing the radiation that doesn't involve radiosurgery. And so, because the 2 of us work together so closely, we both really have to agree that this is the right treatment for you at the right time, at the right dose, and in the right way. And if it isn't, then of course Dr. Wang may be able to handle your problem a different way, and of course I'm perfectly okay with that. Whatever is best for you is where I stand on this. But it's great to work with people in radiation oncology and physics because it brings me back to my engineering days somewhat. I love the precision and the math and the elegance and the beauty of this system. I love how it's evolved over time. I love the results we get for our patients. And I think since we've been early adapters of this mask, and pretty much I'm doing all my patients in this, I've had a chance to get ahead of the curve a little bit, although I'm very busy as a surgeon, I wouldn't say that, we've been ahead of the curve on radiosurgery in terms of that work. No, that's been done by great groups in Europe and the United States who have put out amazing publications establishing the value of radiosurgery in a single fraction of the gamma knife, and those results and that work is just amazing. But this is a new way of doing it, and I think we've gotten ahead of this a little bit. I've been extremely happy with how my patients are doing with these treatments and how they're tolerating this compared to the thousands of treatments we've done here. I think between the linear accelerator treatments and the various kinds of gamma knives here, we're pushing probably 7,000 treatments here at Columbia of various kinds. They're not all my patients, of course, it's the entire institution. But we have really deep experience here in a lot of publications, and I think for once we may have some interesting insights that could be helpful for our patients and the gamma knife community. I hope it certainly turns out that way based upon what we're doing, and certainly our preliminary results would indicate that we're on a good trajectory with this. So radiosurgery is a wonderful thing when you're a surgeon. Patients aren't scared of it. Of course, it pre-selects a certain kind of patient that's destined to get a pretty good result, which is nice. It's reproducible, it's reliable. Like I said, there are very few things in my world where you can do brain surgery and get on the subway train and go back to work after you see me. I don't do pre-op medical testing. I mean, you could be on anticoagulants, you could be treated for cancer, you could have a coronary artery stent. It doesn't play any role in this. The machine only sees the small tumor that you have, and so there's no medical contraindications to this. I don't give any medications to patients for this. I rarely need it. With the mask, you don't really need any sedation at all, although every now and then I'll have a patient take one look at this thing and say, Dr. Sisti, no way I'm going in that. That's fine. Our Gamma Knives and Babies Hospital, look, we can put you under general anesthesia. We can always, I've had some patients who've requested the frame because they don't really like the idea of the mask. That's fine, because the new machine can work on the old-fashioned frame as well as the new mask. And hey, whatever is the right thing for you, if you need the treatment, we're we're not going to force you to do something you don't want to do because you participate in this treatment. You're awake for it. You don't see anything, you don't hear anything, you don't feel anything, you're not radioactive, you're not going to lose any hair, you're not going to get sick from this. That'd be really unusual. And the results aren't a little good. Remember, you're being selected for this treatment. And so because of the design of the machine, its accuracy, its reliability, if somebody's recommending Gamma Knife to you, pretty much what they're saying is, hey, what you've got is small, it's treatable, you don't have a lot of symptoms, and we have a high expectation of a good result with not a lot of complications. Of course, like in anything in neurosurgery, it's just a matter of how many you do. Sooner or later, you're going to see somebody who I say their tumor didn't read the book. And that's where being a surgeon really helps out, because I know if the Gamma Knife doesn't work, then I have the capability of operating on you. So if there's a radiosurgery failure, we can't repeat your radiosurgery, or there's some kind of problem related to the radiosurgery, I'm deeply involved in the clinical care of my radiosurgery patients because they are my patients along with radiation oncology. So if it gets to the point where I think that you need an operation after radiosurgery, well, then I'm your person because I do surgery and radiosurgery. And in fact, I keep hearing that radiosurgery makes the surgery more difficult. That has not been my personal experience. I'm not afraid, if I need to operate on somebody I've radiated, including benign tumors. And I'm not afraid to operate on other people's patients who have been radiated or failed radiosurgery for one reason or another. I don't really find, in my personal hands, that the radiation makes that big of a difference. I guess it could in certain selected instances, but I've operated on a small number of my own radiosurgery failures and many other patients' radiosurgery failures. And I always tell patients, don't feel bad about it. We have a good indication to do the surgery. I don't really think the radiosurgery dramatically changes your outcome, and even doesn't mean after you have radiosurgery and surgery, doesn't mean you couldn't get another dose of radiosurgery. That's possible too. So a lot of patients say, hey, Dr. Sisti, what if I need surgery? Won't it be more difficult? And I say, look, if the radiosurgery doesn't work, I'll make it right for you. I can do the surgery. And a lot of patients ask me about cancer, of course, and of course we can never say never, but if you think about it a little bit, it's really an issue more for the benign tumor patients that have decades worth of follow-up. And so we're using small doses of radiation to very small lesions. So I think if you stay within the parameters of how the machine was designed, that's a very rare occurrence, extremely rare. So I would never say never, but to see cancer after radiosurgery in a properly selected patient is really an ultra rare outcome. And look, I would never dismiss it as a concern, but I think if we have a good indication to giving you radiosurgery, I mean, there's decades of follow-up data of machines that are fairly identical around the world, and I think my experience has been very similar to other people who do a lot of radiosurgery, even more than I do. That yes, we think about it, but that shouldn't be a barrier for us to giving you a treatment that's good for you, as opposed to surgery, which obviously on the day of treatment, anesthesia, invasive surgery carries obviously more short-term risk to you. But I think one of the things about my background in this institution is that the people who do the operations also do their own radiosurgery, and the people who stay within their areas of surgical expertise have deep expertise in the clinical management of whatever it is we're putting a patient in this mask or that frame, because that's what we do all day long. And so experience as a surgeon or radiosurgeon makes a big difference in explaining things to patients, managing problems, selecting the right course of treatment without conflict. I think I call it the European way of doing it. I don't know if they're still doing it that way in Europe, but that's the way we're doing it here. And when I look at my experience and those of my excellent colleagues, I think we're all pretty much in agreement that this technology has made us better surgeons and has given our patients better results. And so we're very proud of our radiosurgery program here, and our use of the new Icon Gamma Knife, this game changer. And if you have any questions, of course you can always reach me at my office or our website, and we'd be happy to set up a consult. One thing I always say is, you're coming for radiosurgery, generally my office staff knows right away. They read your reports, and experienced administrative assistants, I hear them talking to my patients, say, oh, Dr. Sisti, he's not going to operate on your tumor, it's too small. I'll probably set you up to see Dr. Sisti and Dr. Wang from radiation oncology the same day to make it more efficient to you, because gee, Dr. Sisti, when he sees a 10 millimeter acoustic neuroma with symptoms, he stopped operating those 20 years ago, and he's only doing those by radiosurgery. So, sometimes even my administrative assistant, Natalie, will will just tell you what you need without even having to tell you, because it's the indications are pretty defined for this, at least in my practice. So I hope this information has been useful for you. It's not been too overwhelming. You can always go to PubMed and look at some of our publications, particularly on the ICON system. The neurosurgery paper from 2019 is there. It's got some interesting pictures in it, shows you what we can do with it. It doesn't have any long-term outcome. It just says, hey, we started doing this, and this is what you can do it on, this is what you should think about. We'll have results papers coming out. We have some coming out already, but there'll be more coming out over the years, and I'm really looking forward to validating what we think is a big improvement in the way of treating patients with radiosurgery in this particular platform. Thank you.